Speed is very important on the CCS. For 20 minutes, at least you have some time, 20 minutes cases. But when it comes to 10-minute cases, the time is extremely limited. The speed that you get is by practicing it again and again on this Fred software. They're called PRIMUM computer-based case simulations, right? When you download from USMLE.org website, you can download this and you can run those cases and start practicing on them. That's why they've provided this to you. Like I said, a lot of people practice on USMLE World, and that's not the exact replica of what you're seeing here. This software is very intelligent, and I'll show some of this on this case, exactly how intelligent that is. So you have a 65-year-old white woman that comes to the emergency department because of severe left-sided chest pain. And thinking you're able to see the lower part of the screen. If you're not, let me know, but I can show you the whole screen. So here we have, if you look at the lower area, you can see that there is a real time and simulated time. What is the simulated time? Simulated time is actually a patient time. It's running in the patient's case scenario. So you can make simulated time advance a couple of days without moving a minute in the real time. The real time is your time. It has you have 20 minutes real time there, but you have about like a few days here for simulated time, or maybe more based on the case to case, and the case may end if you take it too far in the simulated time. So this person comes with a very high blood pressure, 190 over 90. Heart rate is 110 beats per minute. Temperature is normal. So afebrile, tachycardic, hypertension, a bit accelerated hypertension. So you have a situation like this, and then you start thinking about differential diagnosis. You have a chest pain patient, woman, 67, coming with this kind of vitals. And then you read a bit more on the HPI. The patient, a 65-year-old insurance underwriter, comes with sharp left-sided chest pain 45 minutes ago. When did it start? 45 minutes ago. 9 over 10 radiates to the left jaw and the back. Mildly short of breath. Pain is not made worse by breathing or by change in body position. See that? That's important. Breathing is pleuritic, may indicate a pericarditis or a pneumonia. But body position, same thing, pleurisy or pericarditis. But those are not there. So something is going on. In addition to that, she's hypertensive. She always has been hypertensive and is on lisinopril and hydrochlorothiazide. So I would quickly scan things right there. Look at your real time. Don't miss your real time, because you're at 3 minutes of real time right now. So this is the real time. Look at that, 3 minutes. See? So now the next thing is she doesn't smoke. She drinks 1 glass of wine daily. Family history, father died of stroke. So that's where we are here. Are you not able to see the bottom of the screen? Like elapsed real time, it says 4 minutes. Okay, thank you. So I can spotlight that real time area for you. This is the real time, it says 4 minutes. It's really at the bottom. And the simulated time, 0 minutes, because I haven't advanced the clock. So the simulated time is not going to change. Real time is 4 minutes. Yeah. For people who are unable to see it, it may be because you haven't expanded your screen. So if you want to expand the screen and make it a full screen on your desktops, I think some people are able to see it. So for people who can't see the bottom of the screen, you got to expand the GoToWebinar interface. So you got some idea there what's going on, right? This could be a myocardial infarction, this could be an aortic dissection, this could be pleurisy, pericarditis, pneumonia. Is this pneumonia? No, she's afebrile. Is this a pericarditis pleuritis? No, the character of the pain doesn't change with the position, doesn't change with breathing. So this is not pleurisy or pericarditis. So what is this? This is a chest pain that has started 45 minutes ago, excruciating, and it's in a woman, and with a blood pressure of 190 or 110. Sorry, 190 or 90. So if you don't remember what's going on there, and if you don't remember the vitals, it's always in the screen. You can go back to case introduction and see how she came in. You can go back to initial history and check the whole history there. If there's a doubt. Vitals, you can see your initial vital signs. 190 or 90, 110, tachycardic, right? So what next? So I just told you some differential diagnosis. Myocardial infarction, aortic dissection, pericarditis, pleurisy, pneumonia, panic attacks. You're only going to say it's panic attacks only if everything else is excluded, right? It's in the diagnosis of exclusion. So let's start with an MI. Does she have risk factors for MI? I mean, she doesn't smoke, but she has some family history of strokes, but not really an MI. But then she has hypertension. She has a typical pain. But the pain, on the other hand, here is radiating to her left jaw, but also radiating to her back. Remember that. Her pain radiates to the back, and her vital signs show an elevated blood pressure, 190 or 90. These two are crucial points. So when you have a pain radiating to the back and you have a vital signs with a hypertension, anything more than 160 systolic, typically goes more in favor of aortic dissection, but it could be MI. Both should be kept in mind. But don't forget that this could very well be aortic dissection because of the high blood pressure. It's called a triad through which you can determine whether the patient is having an aortic dissection in the ER. There's a triad. The triad is that significant chest pain that radiates to the back, high blood pressures like this with a systolic greater than 160s, 280, and high blood pressures. And the third one is widened mediastinum on the chest X-ray. If you have 2 out of the 3 criteria, you have about 70% probability as an ER physician to make a initial diagnosis of possible aortic dissection. You're sitting in the ER, you use some clues. It's all about probability. How probable it is. You get some clues and then move towards high probable or low probable, right? So when you're sitting in the ER and you have a pain radiating to the back, and you have a patient with pain radiating to the back, and you have a high blood pressure like that, your aortic dissection is moving up in the differential diagnosis. It's becoming more higher probable, of course, along with MI. But I'm just saying that your aortic dissection is also there, a high probability in this list. So let's approach those 2 differential diagnoses. First starts with stabilizing orders, oxygen, IV access, cardiac monitoring, vitals, and then these are just routine orders, right? They're stabilizing orders. We'll discuss more about those and protocols later on. But I just wanted to show you initially how intelligent this software is. So I'm putting these orders. But don't worry about the sequences. I'm going to discuss in depth about routine protocols, standardized protocols as we move to during the day. So oxygen, IV access, cardiac monitoring, vitals. And then you put in a routine blood test. You don't have to wait for those CBC, CMP, urinalysis, things that people do in the ER. The EKG is getting more specific. So stabilizing orders, routine orders, specific orders. Specific order is an electrocardiogram, chest X-ray, because chest pain. Specific orders means when somebody came with chest pain, I want to do an EKG, I want to do a chest X-ray, I want to do a cardiac enzymes, the routine stuff, you know. Routine means it doesn't matter which diagnosis it is, we're getting some information with some routine tests. These are specific tests. We're ordering some specific tests to find out the etiology of the chest pain. Then we start addressing the symptom. So stabilizing orders, routine tests, specific tests, and then comes address the symptoms. Morphine. I'm going to treat the chest pain. Should I treat the blood pressure? Well, yes, I mean, we should, because the blood pressure is fairly elevated and they're in pain, and you know whether it's an MI or an aortic dissection, it doesn't matter that the patient's pain needs to be controlled and the patient's blood pressure needs to be controlled here. Does it help any if the blood pressure is high in a setting of chest pain like that? If it's an MI? No, you don't want to have that much afterload there. You want to control the afterload and help the heart. Same thing in the aortic dissection. You want to control the afterload and you want to put so much pressure on it, dissecting, tearing aorta. So blood pressure control. You could do it on first screen or second screen, doesn't matter, but quickly. I want to use metoprolol. Do we use nitroglycerin? Not yet. Normally, if you think this is a very high probability myocardial infarction, you're going to do sublingual nitroglycerin or a nitro patch right away. Here not, mainly because we're suspecting aortic dissection also as a higher probability in the differential diagnosis. And when there is aortic dissection, you start on nitroglycerin. What does it do? It increases the heart rate, which is reflex tachycardia, and the heart rate is already up. When you have reflex tachycardia, the aorta tears more. So you don't want to use nitroglycerin or nitroprusside yet, nitroglycerin especially, until we get a diagnosis further. So if it's going more in favor of MI, yes, we will do that. If not, we're going to back off on the nitroglycerin. Metoprolol will take care of the blood pressure. Metoprolol will take care of the tachycardia. You want to cut the tachycardia down. You don't want that shearing stress on this aorta to tear it more. So you want to control the heart rate. You want to control the blood pressure. Those are your priorities here. Oxygen. By using a control button, you can select more than one order with abbreviations. And I have all the abbreviations listed on this PowerPoint slides. They're under your handouts in this workshop. You can download them. And I also have all the abbreviations which I'll go over with you in the first 3 hours lectures as soon as I'm done with this case. But you can, just by putting card, I'm selecting more than 3 orders at once, and that helps me save time here, right? So I'm choosing cardiac monitor, cardiac isoenzymes. How do you know that these kind of things exist unless you practice on the Fred software? Does USMLE have all of this? No. So you got to practice, and then you know that they're all stat. There's no routine orders there. There is no report time orders there. There are no routine orders there. So they're all stat because it's ER. And in cardiac enzymes, typically we want cardiac enzymes every 6-hourly intervals or 4-hourly intervals. So you just keep 3 sites, 4 to 8 hours. You know, there's no clear protocol right now. So confirm orders, vitals at every 1 hour because she's in pain. CBC, just 1. CMP, just 1. Urinalysis, just 1. EKG 12 lead. Actually, we want a regular EKGs. So basically, every 4 hours or so, see if the things are evolving. Portable AP chest X-ray, just 1. Cardiac enzymes, we already did that. Morphine, intravenous. So often a question that I get here is, should I use one time or continuous? Continuous doesn't mean you're running a drip. It just means you're doing as needed. So they don't have an as needed thing here, but continuous means you're doing it as needed. PRN, pain. One time means you're just doing one time. So I would do continuous all the time and just leave it there. So the morphine is getting administered as needed. Metoprolol, IV, again, you know, this one can be one time and you can adjust it later based on what. The other question I often get here is, do I put all these orders before even examining the patient? For stabilizing orders, yes. You got the chest pain, That's enough. So there are two approaches. You can actually do oxygen, pulse ox, IV line, cardiac monitor, go to the patient, do a brief exam, and then come back and write the orders, the lab orders, and the specific tests. But since the patient is in pain, I would recommend that you at least do the stabilizing orders plus the pain medications and then go examine the patient. Pain is the fifth vital. You don't want to leave the patient in extreme pain. They won't even cooperate with you when you're examining the patient. So take care of the pain. So do the stabilizing orders. You can order morphine, then go back and do a brief exam and come back and write the rest of the orders such as cardiac enzymes, EKG, UA, chest x-ray. That's one approach. Or if you did all these like this, because it's easier, which means you're doing basic orders, specific orders, and then pain control, and then monitoring, it's also fine. They're not going to penalize you for that. So we're going to do orders. So select all the systems that you need, but the patient is in significant pain. I don't want breast exam. I don't want head and neck exam. Head and neck, yes, but I don't want like lymph node exam. So this is a waste of time. So the patient is in significant pain. So I want to minimize my exam. So you could do a little bit general exam, cardiovascular exam, abdomen to see if there's any abdominal emergency, head and neck to see if there's a JVD, jugular venous distension, chest lungs to see if there's any pneumothorax or things like that. And that's it. We'll talk about the rest later when we have time. There's no need to do rectal exam, as a lot of cases in USMLE world tells you to do. They say that you have to do rectal exam before you start aspirin. No, you cannot invade a patient with a rectal exam, and then what happens is they're more stressed and they can have more heart attack, right? More dissection. So please, those kind of invasions are not needed when you are starting a benign antiplatelet drug. So here we have on a chest examination, cardiovascular examination, you have 2/6 diastolic murmur, but nothing really going on elsewhere. Moderate distress. I'm kind of rushing because we're running out of time. I just want to show you that trick there, where you have an EKG coming out, which shows really good. I can put these orders, but while I'm showing everything, I ran out of time here. But normally you won't run out of time in the exam here because I'm talking to you. So you can see when your chest X-ray is coming up, mediastinal widening with indistinct aortic knob. That's your third criteria, isn't it? I lost the time. I have only 2 minutes left. I can't really do much here. So impression, mediastinal widening with indistinct aortic knob. So we have a situation where you have the third criteria met. So this is going more in favor of aortic dissection, and the MI is going very low in the list because you just saw an EKG, which was good. So if this happened to you on the real exam for some reason and the case ended, what do? Don't panic. Yes, you lose some score because you haven't done much. You haven't addressed the etiology yet, but you have gotten a lot of score. You've done what's necessary. You treated the pain, you treated the blood pressure, you got it down, you're monitoring vital signs, cardiac enzymes. You're doing so much. You already got about 50% score. Rest, of course, was needed was to do a CT scan of the chest to confirm where the dissection is, stat, and to call a cardiothoracic surgeon. Of course, that would have been more useful if I had the CT report. Here I can't because I don't have a lot of time. So at least put in those orders so you take care of it, and you're telling the software you took care of that orders. So you lose some score for not navigating the clock here properly, but you're still going to get a lot of score because you didn't forget to mention those two in the 2-minute screen. So don't forget that. So if the case ended and this happened to you on the real exam, make sure you put in those crucial orders before you exit the case. Diagnosis. Doesn't matter what you type here. The software doesn't read what you type. The software only picks up the things you got from its algorithm. All these things is in its algorithm. So that's what software picks up. So don't waste your time on typing too much in the diagnosis bars. So let's repeat this case since I was talking to you too much, then we ran out of this. time. So what we do is we'll go back and do that case again, this time quickly, and I'll show you how it changes in the sequencing, because that's what I wanted to show you really. I wanted to show you how this how the same case will behave when we do a particular order in a different way. So 65-year-old white woman, so you're able to see that, right? 65-year-old white woman comes to the emergency department, severe left-sided chest pain, appears anxious and diaphoretic. It's the same case. You have simulated time here. You have real time here. Simulated time moves when you advance the clock by actually choosing the clock. Real time moves as you wait. Real time is your time. You have only 20 minutes, 18 minutes for the actual case, 2 minutes for the case ending screen. And you just saw what happens if you spend too much real time thinking about it or typing too many things without knowing what you're doing. The real time ends and you don't have enough time to put in orders and move the case. And the 2 minutes came in and you put some orders there, but you didn't really finish the case. So you did lose some score there, although you got probably, I would say, 60% score, but that's not our idea. Our idea is to pull your graph towards the right side, extreme performance, excellent performance. That's what we want. So you got to finish all the components to get there. So you got to watch your real time. Real time is just because you want to finish the case. You got to watch your simulated time. The simulated time is the patient time. When you advance the clock, it runs. So you got to watch your simulated time, because if the patient time moves too far ahead and you're not doing anything, a critically ill patient can suffer. And during that time, you lose point. So simulated time is scored. How soon you address the case, how soon you treat the patient. Simulated time gets scored. So make sure that you pay attention to the simulated time while you are doing. So let's say if you address this case in a day, as opposed to you addressing this case in 2 hours, the 2 hours guy is going to get much higher score than somebody who finished the case in like a day. So go to here, same case, 65-year-old white woman comes to the ER because of severe left-sided chest pain, right? The vitals is a very important screen. Afebrile. You got to start from there, because if somebody has a fever, the whole case and the differential diagnosis is shifting in a different direction. Pneumonia, sepsis. Whereas your afebrile, those go to the bottom of the list. The heart rate, 110 beats per minute. So tachycardic. Make sure you don't forget that. Then you have high blood pressure, accelerated hypertension, 190/90, systolic blood pressure at 190. And I told you a triad of aortic dissection, chest pain radiating to the back, tachycardia, sorry, systolic blood pressure greater than 160 is like this. So all this goes more in favor of aortic dissection. I have 70% pretest probability for this being an aortic dissection, with other differential diagnoses such as myocardial infarction in the list. The patient's chest pain radiating to the back, like we just went over the history a few minutes ago. So she doesn't smoke. So let's go back. What is the other way of doing this? So oxy, vitals, cord, right? So IV access. And somebody asked me, should I just put in investigations right here? You can. That's a good approach. It doesn't matter whether you did it right now or did it after the physical examination when it comes to the investigations. There's only a 4 or 5 minutes difference there, and that's okay. As long as you address the fifth vital. The fifth vital is the pain. You don't want to go to the patient without addressing their pain. Give them something for pain, excruciating left-sided pain. You don't want to completely start a full physical examination before you start the pain. Should I address the hypertension? You can right now, or you can do it immediately after the physical examination. I'm just showing different scenarios. Both are acceptable. The previous one, if it's easy for you, where you put in all the orders at once, the specifics, routines, it's okay. You're not going to be penalized for that. This particular approach is probably a bit more sophisticated, because like you will get some clues from the physical and you will know what orders to put. But for a routine orders, you really don't need a diagnosis, like for CBC, etc. So yeah, you can go either way. But this is the approach that I would prefer. Usually, like I would do a few things like routine orders first and give them, treat their pain, go back, do the exam, and come back and do everything. That's what we do in the clinical practice, right? So cardiac monitor. If you see, I haven't chosen cardiac enzymes because those are specifics. So I'm just going to give them morphine as needed for pain. I'm not putting nitroglycerin because while I was telling you about the presentation, I was telling you aortic dissection was also a higher probability. So it's going, I don't want to put nitroglycerin because as you put nitroglycerin in the orders, it increases heart rate. When it increases the heart rate, you have more shearing stress on the aorta. And if it's an ascending thoracic aorta dissection, we don't know yet, but if it is, it'll tear it more. So you don't want to use nitroglycerin and dilate the vessels and cause reflex tachycardia. Reflex tachycardia is a side effect of IV nitroglycerin or sublingual nitroglycerin. You can use metoprolol, but then again, specifics, I haven't moved any inpatient time. Look at that. I haven't moved any in the patient time. I haven't advanced the clock. So I can do a bit of a physical exam, come back and take care of the rest of the things. No rectal exams, no breast exams, etc. Nothing that it'll add. 98% oxygen saturation. 190/90. Sinus tachycardia, which is what we saw. A cardiac monitor is important because it will give us an idea of arrhythmias. If there's a VTAC or AFib, it's going to tell us. But it tells us it's sinus tachycardia, which is something good. I mean, it's not that bad, like a tachycardia, or like a ventricular tachycardia or VFib. So we're not doing something. We're not getting into something really bad. On the other hand, if your cardiac monitor popped up like that and told you that there is ventricular fibrillation, what are you going to do? You're not going to advance the clock. You're going to hit okay, but you're not going to advance the clock. Because once you advance the clock, remember, it moves to 6 minutes right there. So if you saw a cardiac monitor and gave a VFib, stop the clock right there. Stop the clock right there. At each pop-up window, like whenever you have a pop-up saying you have a ventricular fibrillation or something like something threatening, or even something very simple, after each pop-up window, this software, not the others out there, but this software, the exam software, will give you a thing to stop the clock and address it. So when you stop the clock and put in the order, that's how you're scored here, because you addressed it right there, something an emergency, and didn't let the clock advance. Now in the real life, it's common sense. People will do that, but on the software, they don't realize that when you hit OK button, the clock will jump, and you lost your opportunity to address a ventricular fibrillation at 5 minutes of simulated time compared to 10 minutes. You wait 5 more minutes with a VFib, you're not going to wait. It's a code. You're going to call, you're going to stop the clock, start immediate defibrillation. So you have to activate the code there, right there, and all the steps in the code. So right, that's the difference between this and um, advancing the clock right away. So how do you know? So I'll show you a few more right there. But you can see that you got your interval exam and everything. Now you go back to your order sheet, put in the orders. We got the stabilizing orders already. We got some pain control already. We got to control the blood pressure. Remember, it's still very high. You don't want to leave. Either it's an MI or it is an aortic dissection. We don't know, but we don't want to leave them with a very high blood pressure right there. It doesn't matter. Metoprolol is good. So what else? Specific orders. EKG, cardiac enzymes, chest x-ray, which is what I'm doing for a chest pain protocol. Routine orders, doesn't matter, CBC, CMP, urinalysis. The reason I always want routine orders, and most of the ER physicians would always do the routine orders, is because you got to know whether the patient is anemic. You got to know whether he's hyperkalemic or renal insufficiency. All of these add up to the case, how you manage the case, the risk factors, right? How would you know if you didn't order those? Some people think that they're ordering too much and they don't want to order CBC, CMP. You can. I mean, those things you have to order because a person may be anemic with an MI and it is of importance. If the hemoglobin is 6.8 or 8.2 and he's coming with an MI, of course you want to give blood transfusion, right? So those kind of things, you want to prevent ischemia, right? How do you get that information? Sometimes a step 3 leaves them in those hidden orders. They're just routine and they expect you to do that, and that's how the information opens up. It could also be an electrolyte imbalance such as hyperkalemia, hypokalemia. That's how the information will open up when you order the routine orders. All right, so we're good here. Metoprolol, CBC, CMP analysis, and we got to check those specific orders to move forward to know where we are, right? I'm not giving nitroglycerin, I told you why, because based on the criteria, pretest probability of aortic dissection is high. So I'm staying away from nitroglycerin. But rest of the MONA, morphine, oxygen, I have given. I'm not giving aspirin yet. You can give it if you think it's very high probability, but we don't want to if you're thinking about aortic dissection. Aspirin is okay, but not Lovinox, etc. when you have a dissection. Routine orders doesn't need a frequency unless you have a specific case like ITP where you want to check CBC every 4 hours. So I just put one time. EKG, and since I'm suspecting an MI, I want a serial EKG. Cardiac enzymes. Since I'm suspecting an MI, I want serial cardiac enzymes. Chest x-ray. Since I'm suspecting etiology is related to chest pain, I want one chest x-ray to find out whether there's pneumonia or a wide-end mediastinum, etc. Now, nothing will happen if you sit here. If you're looking at it and thinking about it, the case won't move, you won't get your orders back. The order time is this, but the report times are way away. So like, cardiac enzymes, you don't get it until 11 a.m. EKG, you don't get it until 10:21. What is your most important order? It's an EKG. So you want to probably advance the clock to get to the EKG and find out what's happening right there, and the chest x-ray to get to that point and find out what's happening there. So right now the time is 6 minutes past 10, but you see 10:06. But 10:26 is when you will get this x-rays back. So you want to advance the clock. So how do I advance the clock? Different types. You can put 26 right there, quick. Some people find it easy to do it like this with the next available result. So you can advance the clock like that. Some people can go back and do the rest of the exam, but there was not much exam we left behind, so we don't have to worry about that. So partial pain relief from medication. EKG 12 lead shows sinus tachycardia. So see, you're not having any ischemic changes there. You don't have either, like a T-wave inversions, etc. a little bit, but non-specific, but not really T-wave inversions or ST elevations. So it's not an ST elevation MI. So we're beyond that. So we're good. Remember I said it's not an ST elevation MI. I didn't say it's not an MI. It could still be a non-ST elevation MI when the enzymes are up. But it's not an ST elevation MI, which is an emergency. We're not dealing with that. So we're going to keep going for our chest x-ray. Chest x-ray comes back, gives us our third criteria for aortic dissection, pretest probability. Mediastinal widening, very high pretest probability for aortic dissection. Now the likelihood that this is aortic dissection is 90%. So we got our pre-test probability as 90%. Why am I saying it's pre-test? Because I haven't done a conclusive test to find out whether this is aortic dissection. Our pre-test probability is 90% because chest pain radiating to the back, accelerated hypertension, widened mediastinum is going to 90%. But I don't have a confirmatory test yet. What is the confirmatory test? A CT chest, because we want to make sure this is whether this is ascending thoracic aorta or descending thoracic aorta. Chest X-ray shows widened mediastinum. What else can do that? I mean, with the chest pain, it has to be aortic aneurysm going on with a dissection or a dissection, you know. So you got to find out whether that dissection is ascending or descending. Just because you have criteria so far for aortic dissection, it doesn't mean you have to call cardiothoracic surgery right away. You already started treating the blood pressure, isn't it? So you got to continue to monitor blood pressure and put the cardiothoracic surgeon. But I'm just showing you various scenarios. Reason for consult is not scored. You don't need to type much there. The software is not reading it. Software is only counting you, scoring you for the things you select from the previous, from what it gives. It's an algorithmic process. All right. So we're going to advance the clock to see what the thoracic surgeon is going to say because I want to treat the dissection. The blood pressure is excellent. Awesome. How did that happen? Because we gave a metoprolol and the blood pressure is coming down and the heart rate has come down. How did that happen? Metoprolol. So when you give the medicine and when you're checking the vital signs, how come these vital signs popped up like that? They didn't pop up on their own. We set it. We set monitoring parameters when we started. So all of this is being scored when the case is running and when you're advancing the clock. CBC looks good. Urinalysis looks good. Next available results. Consult cardiothoracic surgery. So you call a cardiothoracic surgeon to intervene on a thoracic aortic aneurysm and he says he has no management recommendations. That's not good. So you start thinking, is there something wrong with the case or is that how software is? But some people that I know kind of got an interpretation, especially from USMLE world, that even when you get an order like that, you can just proceed and put in the surgery order, etc. That's not true. That is on USMLE world software because it's not tricking you. Here it is clearly tricking you for sequencing. Sequencing is first find out whether it's ascending or descending aorta. The criteria for surgery is as an ascending thoracic aorta dissection right away, not for descending. So let's see what the CT chest shows. Is it ascending or descending? Cardiac enzymes come back and they're normal. See, now the CT chest says ascending aortic dissection here. Now with that information, call our surgery again. Oh, sorry. I should have shown you that. I'm talking too much. So see again. Now what happened here? So you got to a cardiothoracic surgeon and you couldn't finish the case because you couldn't advance the clock because you ran out of the real time here. That's because I was telling you, explaining too many things. So here, that's what I'm trying to say. So when you get there, you want to make that happen. You want to make that surgery happen. That's when you're done. You're not done here yet. I mean, you'll get a lot of score for doing so many things, but we missed out on the crucial point there that we have to make that surgery happen. But I was trying to show you various sequencing scenarios. It won't run out of time on the exam. I'm showing you various scenarios. That's why it's taking time. So a scenario one is where you're calling the surgeon and didn't even put the CT chest, or you put the CT chest with the surgeon together. What happened was it'll refuse. The software will refuse the surgery. A scenario two is, excuse me. Scenario two is that, so where you put cardiothoracic surgery right away, but not a scan. So concomitantly or surgical consult before the scan, he's going to say no. But if you get the scan first and confirm that this is ascending thoracic aorta, you have met the criteria for surgery. The criteria for surgery in a thoracic aorta dissection is ascending thoracic aorta dissection. Once you meet the criteria of surgery, isn't that what it is? Once you meet the criteria of surgery, then you move to the next thing. Now I'll demonstrate that quickly to you because this is very crucial. This is sequencing, monitoring. We've already addressed so many things, you see. In one case, you can know integral components of the CCS totally. Diagnosis, locations, which we haven't done yet. But sequencing, monitoring, and treatments. 5 components. Diagnosis, location, monitoring, timing, and sequencing. Timing is about simulated time and all that stuff. So diagnosis, location, monitoring, timing, and sequencing. So you want to keep the simulated time low. You want to keep monitoring like we did. All that vitals that were popping up as we advanced the clock didn't happen magically. You set it up in the beginning. We ordered them beforehand. And that's running in the background. And that's counting as monitoring parameters. And that's helping you to know how the patient is doing and what intervention you need to take. And all that is gaining score for you. So let's quickly do this. And the 5th vital, the pain. Address that. I'm using a control button, selecting the multiple orders. Set up monitoring parameters. If you don't set up this, as you move the clock, it doesn't magically pop up. You got to select those. Frequency. Cardiac monitoring. Why is that important in chest pain? Because sometimes you have arrhythmias, and if you put cardiac monitor alone, it'll show you one time, but it won't keep checking again and again. If you put a check every 1 hour, it's like telemetry. It gives you a pop-up, and it gives you a pop-up saying there's an arrhythmia right now. What do you want to do? So cardiac monitor and cardiac monitor check, especially for chest pain cases, choose that. As needed for pain. So once we put them, the simulated time is not really running yet. It will only run when I do a physical exam or when I advance the clock. A simulated time is a patient time. You could do some of those. I don't need a neuro exam right now. We can come back and do them. We don't need a breast exam. We don't need lymph nodes, skin, etc. We can come back and do skin and lymph nodes, but the breast, genitalia, rectal should not be done in patients who are in extreme distress and chest pain like this. When you do those invasive exams, you automatically fail on those cases. The patient is in distress, you don't want to do those invasive exams. And then systolic blood pressure is 190, diastolic is about 90. So we talked about that. Cardiac monitor, this is how it gives you the alerts. Sinus tachycardia. So what is the importance of this particular screen here? Right? This particular screen. What's the importance of that? Each time when a patient comes, when a pop-up comes and gives you a vitals or gives you a test result, it'll ask you whether to stop now or continue. This is important because if you stop now, you can address that right away. But do I have to stop now? I don't need to stop now for sinus tachycardia. But if I had a ventricular fibrillation, do I have to stop now? Yes. I have to stop now and address it right now. There's another issue. Some people may have hypoglycemia, right? They're comatose, they have altered mental status, their blood sugar when you checked is about 40. It'll pop up like that. The blood sugar is 40. And as you're advancing the clock, you've missed this sometimes. You're in haste, you're in a hurry, and you may hit a continue button again. So that's not acceptable, because once you say continue after seeing a blood sugar of 40, your clock here may jump to 30 minutes later, depending upon when the next test report is going to come. A lot of people miss on these things because this is not your real life scenario. This is a software. It's giving you some algorithms. So when you click on that, you lost the 30 minutes. That's what the software is going to say. It took you 30 minutes to address a blood sugar of 40, and automatically you get a significantly negative score. So that's what I'm saying. This screen is important based on the case, based on what pop-ups you get. So we do not stop for all abnormal findings. For example, sinus tachycardia is also an abnormal finding. Do we stop now? No, it's just a sinus tachycardia. It doesn't need to be addressed right now. We already are going to give metoprolol, but not right now. So, but if it's a ventricular fibrillation with a hypotension and somebody is in shock, we got to stop now. If it's hypoglycemia, we got to stop now and then put in those orders. So those are certain things that we need to know. So sorry about that highlighter there. Yep. Okay. So now we have cardiac monitor saying the same thing, because it always tells you stop now or continue. A lot of people didn't understand the importance of that. So the reason the stop now it is given is because of an emergency finding. If it is there, you have to use stop now. The software is not going to tell you what's an emergency. You have to make the decision. Every time it presents you a screen with results or a monitoring parameter, it will give you the interventions, stop now or continue. Now you're continuing. You get to your physical exam findings. All you find is a diastolic murmur, no JVD, no pulsus paradoxus, certain things you look for there to differentiate between various things. You don't have a pericardial rub. You don't have a pleural rub. So you're ruling out some differential diagnosis in that chest pain. You don't have a decreased breath sounds. So next what? Next is the specific orders. So what are the specific orders that we talked about? Start with routine, CBC, CMP, urinalysis. Next, go to the specifics, EKG, cardiac monitor. We already ordered cardiac monitor, so cardiac enzymes. And chest x-ray, sorry. Because it's chest pain, right? So you want to also order a chest x-ray. Because you're suspecting an MI, you want to set up a frequency for a serial EKG. Because you are suspecting an MI, you want a serial cardiac enzymes. And then you get a chest x-ray. While I'm talking, I repeat a lot. The reason I repeat is because redundancy is always good. When you repeat, it gets imprinted in your brain. That's pretty much what it is. So I repeat a lot. So if it's boring, let me know. But basically, the repetition is so that it really sticks in your brain. At the end of the day, it won't leave it. So that's why. So that's one reason. So we got to continue to do these things, and you master it. With one case, you kind of master so many tactics, strategies there, sequencing, monitoring, timing, how to follow up the interventions. So we have a chest x-ray here. So you look at this here, the report time is 10:27, cardiac enzymes 11:07, EKG 10:22. So you have those report times. So advance the clock. Some people choose to advance the clock with next available result, which is perfectly fine. Or since you know your report times for those important tests, advance to those important tests to get there. Either way, remember, just because you put in like this, like an hour later, you're not losing the case. You're not losing your control on the case. Why? Because you always have an option to stop now. If something emergent pops up, the software always gives you an option to stop now. You're not going to jump to 10:27 just because you chose it here. You're not going to jump there right away. Each time when something pops up before that, the software gives you an option to stop the clock. The patient has partial pain relief. What does the software says next? Stop now or continue? When you continue, you're moving towards your 10:27, which you selected. You see? So you're not losing a control on the clock. just by setting a time there. EKG has come back. Sinus tachycardia, no ST elevations, non-specific abnormalities. Again, look at that. Stop now or continue. Why? If the EKG showed ST elevation myocardial infarction, do I still need a chest X-ray? Not really. I wanted the chest X-ray because I'm thinking about aortic dissection a bit more higher in the probability. To continue the previous case, I told you the triad is widened mediastinum also in the chest X-ray, along with hypertension and tachycardia and chest pain radiating to the back. So I was going to meet the triad and I got the chest X-ray done and I advanced the clock to 10:27, but EKG popped up in between. And in this case, it's not suggesting an MI. But let's say in another case like this, it suggested an ST elevation MI. Would you still go to your chest X-ray by saying continue? No, you're going to stop now because that's it. We got the information, ST elevation MI. You're going to activate the STEMI protocol, which we'll discuss later. Morphine, oxygen, nitroglycerin, aspirin, metoprolol, low molecular weight heparin, call cardiology consult, order cardiac catheterization. All this is STEMI protocol, right? You'll activate that right now by stopping the clock. In this case, that's not what happened. It's not ST elevation MI. So we choose continue button. So when you choose the continue button, you have mediastinal widening within distinct aortic knob. You met your third criteria, that's aortic dissection. So what do you do next? Now is what I want you to know about sequencing. A sequencing of cardiothoracic surgery consult. Before knowing whether this patient is a surgical candidate is a wrong approach. I told you the reason for consultation doesn't matter. Don't waste your time on that. But if you want to be specific, you can put something like A or whatever, but don't waste a lot of time on that. So your cardiothoracic surgery consult is coming back at 10:42. So let's advance the clock and find out. The thoracic surgeon is saying he has no much recommendations. Really? The patient is in pain. He's calling no recommendations. Why? Is he not a good consultant? No, that's not what it is. You haven't met your criteria. You haven't met the surgical criteria. The surgical criteria for aortic dissection in a case like this should be ascending thoracic aorta. Have you proven that yet? You haven't proven that yet. How do you sequence that? So some people think of sequencing like this. Now what did they do? They ordered the two concomitantly. A concomitant orders. Look at what happened here. I want you to notice this very carefully. Right? Look at this. What happened here? Cardiothoracic surgery consult is coming at 10:57. CT chest is happening at 11:12. Now what happened to your sequencing? A CT chest is coming back after the surgical consult. The cardiothoracic surgery is still going to see the patient before the CT chest comes back. And he's going to say no. Is that a real no? No. The software is tricking you. How much do you know about surgical criteria? How do you sequence? Are you following the protocols? Same response. At this time, the consultant has no recommendations. Now what? Now you're stuck again. But at least I want you to remember, if these things happen to you on the real exam, I want you to remember that you're not done. I mean, you know certain things. It's just that you haven't sequenced properly. Make sure you see that CT chest. Proceed with the clock. So the sequencing should have been that you should have noted and seen the CT chest results with your eyes. Look at that. CT chest has come back. Now you have ascending thoracic aorta dissection, impression, ascending aortic dissection. This is a surgical case. We have determined that this is a surgical case now. Now you call cardiothoracic surgeon. Let's see what he says now. This is exactly what I want to show you because this is crucial. A lot of people practice on USMLE World and it's coming out wrongly there. And they think that's it. That's one of the reasons why people are practicing so much of USMLE World, right? Because it's very well promoted. And why they don't pass. Why they do so badly on the CCS. So certain things. So things like this. So well, let's go with the next one. When you don't get the concept right there, it changes. See, a simple sequencing changes the response. The software is intelligent. The response here is the patient will be scheduled for surgery. Please continue with medical management. A simple thing. That's exactly what I want to show you. So sequencing, how important it is. Just remember, you have to know your surgical criteria before you call a thoracic surgeon or any intervention. So they're looking for that sequencing. Is that all with the sequencing? Is it just with the consultants? No, many places, even in tension pneumothorax, some people think they did a follow-up chest X-ray. What they do normally is like they put a chest tube and they also put a chest X-ray together, thinking that they will happen a chest X-ray after the chest tube. But it won't happen because the software, it's not like in real life that people know when to do it. Software basically gives a report time based on the order time. So your order time should fall after the chest tube placement. So you put the chest tube, you advance the clock, you get to putting the chest tube, you confirm that the chest tube is placed, and then order a chest X-ray. That's when you finish your follow-up X-ray, and that's when you get the score. That's sequencing. So now you have now since the thoracic surgeon accepted the patient, you can put your pre-op order sets. So what do you want to put? So basically type and cross match, blood transfusion issues, and then NPO. You already have IV access. Put some fluids, and then PTT, and then you want to get consent for procedure. Doesn't usually matter for emergency surgeries, but you can type consent if you want. And then you want to type in the name of the procedure itself, either thoracotomy, because most often that's how the repairs are done, right? Or you could put aortic aneurysm repair, or all of them will be stat. We have 14 seconds, real time left. I have 9 seconds. See, you think time is so fast there, so you got to finish all that. So basically, we want to let that name of the procedure go through in the orders. So do not put the name of the procedure before you meet the criteria for surgery. That is wrong. You got to meet the criteria for surgery, and when the surgeon accepts, that's when you put the name of the procedure. That's real exact sequencing. So that's what I want to demonstrate. But yes, we did one case so far. It took us time, but we've covered so many things. That's what I wanted to show you. I mean, how important this is to go. So let me quickly pull out something here. Give me a couple of seconds, and I'll pull out the pre-recorded video, which is for strategies. 1 second. Thank you.
Yes, I was just wondering, because I've heard from someone who just took the exam recently. She said that on the real exam day, the software will have some delays in terms of like the test results and stuff. So she actually suggested that we should not order that many tests so you can finish on time. I just want to know, is that true, or have you heard about that in the past?
Yeah, like, typically it shouldn't happen, right? I mean, if you look at this software right now, what we're seeing is we're looking at Fred software, and I'm doing it right in front of your eyes, and it's moving so smoothly. So it should happen.
Yes.
Yeah, it should happen right like that if the internet connections are good in the prometric center. Um,
Okay.
yeah, I mean, sometimes there is a test location issues. So
Okay.
yeah, otherwise it's so fast. You can see that how well it went through. But unfortunately, here and there for people, it may happen like, it could be internet related, or in that case, you should report to the proctor. You should let them know, and, they can note it down in that way. Um, at least the
Uh,
test people know about it.
all right, that's good to know. Thank you.
Yeah. So that shouldn't happen. And of course, we don't want to order anything unnecessary there. Typically, we want to order what is necessary, but sometimes it's hard to figure out what's exactly necessary. That's why you need some routine tests, because those routine tests will give you clues. Like, how do I know what is exactly necessary if somebody is coming with just a fatigue, and or somebody is coming with a chest pain, until you order some routine tests at least, or let's say if somebody comes with dehydration, and their situation is bad, you want to get the CMP, everything, and sometimes you're surprised to find out things like hypercalcemia on your basic metabolic panel, which will totally change your case in a different direction. So CCS software throws in things like that on the exam, because that's how your cases come to the forefront. So those routine tests are almost always needed, and we're not doing anything out of the guidelines. Any ER, when you go to the ER, this is what happens, right? They at least gets your CBC, CMP, and urinalysis, chest X-ray based on your pain symptoms, and then go forward. So things like that. Not everybody gets chest X-ray, but people who come with pain and respiratory distress, they are all getting chest X-rays. So things like that. So you have to order those tests and advance the clock. And 99%, the software should not delay you there in presenting the test results. Like I'm just practicing right now on Fred software, and as you can see, it's very fast. It moves fast. When your connections are good, it moves very fast. Um, Anybody else have any other questions? Otherwise, we'll go to the CCS strategies 3-hour lecture.
Fred, can you hear me?
Yes, go ahead.
Yeah, so say if we have an obscure case and, we place some orders initially, and then we think that, based on our management or some of the results we're getting, it's leading us towards a diagnosis we maybe weren't considering early on. I mean, is there a way to cancel any orders that you think might be unnecessary and then redirect your orders in that way? Like
Exactly.
is there a way to do that?
Exactly, because that's why you have stop now again. So you've ordered so many tests and you decided to proceed to a farther time in the simulated time, right? Let's go to the advanced clock, put in a day later, but you didn't lose your grip on the order sheet or on the patient. So the clock automatically doesn't jump to the next day, even though you chose next day. It starts giving you all the results which you've already ordered. Based on those results, you may change your mind. You may say, well, this is not what I'm thinking. This is showing, I mean, for somebody with a dehydration, it may come up with hypercalcemia, right? So
Yes.
this is not what I initially thought. It's not a simple dehydration. It seems to be hypercalcemic crisis. Then I just stop the clock and go back and do all my orders, or change it and approach with hypercalcemic crisis protocol.
Oh, wonderful. So you can actually go back and just cancel or change it according to, like, if you're suspecting the hypercalcemia protocol, you redirect towards that basically. Okay,
Exactly.
that's great to know. Okay.
Yeah.
That answers my
Because
question. Yeah.
yeah, because as you know, they didn't happen. You ordered them, but they're in the future time before you saw the calcium level.
Yes, correct.
So you get to
Awesome.
stop and move. What some people do is like they don't they forget about the stop now button, and then they put a continue. Excuse me. So it just jumps to the next day. It won't still jump, but it'll keep on moving ahead, and in that process you lose time.
I see. Wonderful. Okay, thank you for addressing my question.
You're welcome.
Right.
Hi.
In the case of aortic dissection, I mean, I know that we have the result in the CT with contrast about that is ascending, is the dissection is in the ascending aorta, and then we consult surgery. But if we didn't have time to put the specific surgery, that thoracotomy, because the time ran away. So we're gonna lose points. It's just not enough with the consult.
Maybe a little bit in cases where you need to put in the procedure name itself to direct the surgeon. But the problem here is like normally you don't tell the surgeon to do what way to do, right? I mean, you in real life, but in the software you have to put in the procedure name as well. And usually you want to put them as a part of your pre-operative orders. Like once the surgeon accepts, then you put your pre-op orders, right? Like NPO, IV titration, PTO, PT, PTD, and all that stuff. So when you're putting that, you put the procedure name itself too. So just remember that, like procedure name goes with the next rest of the order set in pre-operative setting.
Okay, but in case we didn't have time to do that, the points that we're going to lose is going to be many points or just?
I think it's going to be minimal because the surgeon has already accepted, and that's where the maximum there would be for sequencing and getting that done.
Got it. Because sometimes I had some friend that they did a consult and the consult said, yes, the patient will be take care, and then the case closed.
Exactly, because that's all they're looking for, really. Yeah.
Got it. Okay. Okay. Thank you, Dr. Red.
Great.
So if the patient is on several medication, when we go to the order sheet, do those pop up automatically or do we have to put those in again?
Yeah, whatever you have continuous, not like one time, they're all there. They're all there.
No, I mean like previously, before they're seeing you, let's say they were on hydrochlorothiazide, like before.
That's very important. Yeah, very good question. They're all there. That's very crucial because sometimes you have patients coming in with, let's say somebody came with dizziness and you don't know what's going on. And then you check their vitals, they look good. And then you go to the order sheet, you check, you see some things like diuretics on board.
Okay.
They're there. So
they're there. Okay, great.
Yeah, then it gives you a clue. Dizziness, diuretic. So let me order orthostatic vitals. Unless you order orthostatic vitals, they're not going to pop up, right? So you order them and you find that they're orthostatic hypotension. They have orthostatic hypotension. Then you have to go to that order sheet and discontinue the hydrochlorothiazide, and that's really scored.
Okay, thank you so much.
You're welcome.
A UWorld case, and you said that the emergency cases usually you don't transfer them, but it was like with an aneurysm case, they wanted you to transfer to the ICU before preparing the aneurysm. I guess this is different etiology, but you're saying most emergent cases you wouldn't transfer, other than I mean for the chest.
Right. So let's go back. Let's go back. There's a little echo. I'm going to mute you again, and then let's go back and revisit that again. So basically, what I'm trying to say is, let's say if you have aortic aneurysm and it's stable, right? I mean, there's no rupture going on. The vitals are okay. Then you have time to do an elective surgery. It's not urgent. It's not emergency. It does not need to happen right away. But whereas the same aortic aneurysm in the abdomen comes with a rupture and the vitals are very unstable, he's in shock, you do a fast ultrasound right next to the bed, and then once the ultrasound picks up that there is rupture going on, then you have to call the surgeon right away and then transfer them to the OR. I mean, the OR is not there in your location. So once you call the surgeon sets up the surgery and it's done. Then once the patient is returned to you after surgery, then you can change the location to ICU. Contrast that with